So let's get into the more complexities of the biceps tears. So when you have just a biceps tear, again, the key here is you still can flex because you have other muscles that allow you to do that. You have weakness there, but really it's people talk about screwing in a screwdriver. It's that supination strength. These can be usually diagnosed from the exam itself, but also MRI is helpful. And they come in different flavors, such as tendonitis, where it's a partial tear. Those are a little more challenging in the sense that patients tend to have a lot of pain. The ruptures don't have as much pain. They tend to have the weakness or the deformity. Some patients live with it, but obviously if you're active and you want to get back to strength activities, generally recommend surgery. And within the first 6 weeks, mainly to try to reduce the chance that it's too far up the elbow, or the humerus, to fix. We usually fix it primarily if we can. Button fixation is my preference. And the key here is, again, you can fix it almost up to 90, 100 degrees, and they will stretch out. So most of the time we're doing that. Occasionally you have to have a graft, which means we use usually an Achilles allograft, and we can reconstruct that area there. We tend to avoid that as much as possible, but we have had cases where we've had to do that. And generally, we talked about that sort of a two-surgeon approach, especially with finding more complex nerves up in the elbow and humerus.